it is my pleasure to introduce my colleague, Fernando Carvalho Poiras, who's one of the real rising stars in the division of neurocritical care. She's going to be talking to us today about preventing secondary brain injury after intracerebral hemorrhage. Dr. Carvalho received her MD and PhD from Columbia University, where she did a dissertation on basal ganglia, how the basal ganglia regulates motivated behavior. She then did both neurology residency and neurocritical care fellowship at Columbia before coming to join us at Mount Sinai in 2023. She is one of the more active researchers in our division and is currently looking at inflammatory response after intracerebral hemorrhage, which seems like it's directly related to her talk today. So I'm going to turn it over to Dr. Carvalho Poiras, and looking forward to a great talk. Thank you.
Thank you, Cappy, for the introduction. So the title of my talk today is Preventing Secondary Brain Injury After ICH. First of all, wanted to say that I don't have anything to disclose. And the objectives of my talk are listed here. Essentially, it's fourfold. I want to talk a bit about the hyperacute management of ICH and review best practices there. I want to talk about the different types of secondary brain injury that can occur after ICH, as well as their underlying mechanisms and risk factors. And then I'm going to evaluate a number of clinical trials aimed at preventing secondary brain injury after ICH. And in the end, I'm going to talk a little bit about, touch upon minimally invasive hematoma evacuation in ICH. And with all that, I'm also going to discuss some of the data that I have generated with my own research. And I hope that this talk is informative and also interesting to you. So to introduce this topic, you all know that ICH is a type of stroke. It is the subtype of stroke with the highest morbidity and mortality. And we know from some data that the incidence of ICH has not really changed over the past decades, and it's not really expected to go down because of the aging population and the widespread use of oral anticoagulants. In terms of acute medical management of ICH, we're really limited to trying to prevent secondary injury. And there are three ways we can do that. I'd say the first one is focusing on hematoma expansion, which includes blood pressure control and reversal of coagulopathy. In some patients, there are issues with intracranial pressure. So intracranial pressure management is another way we can prevent secondary brain injury. And then these patients end up staying in our ICU for a number of days. And during that time, I like to believe that we're also helping prevent secondary brain injury by optimizing conditions for them, even though we don't have very targeted therapies to offer at this time. However, there are new therapeutic strategies being developed for ICH, specifically targeting cerebral oxygen delivery, iron toxicity, perihematoma edema, and inflammation. And hopefully in the future, we'll have more therapies to offer our patients. This is a framework that I developed to kind of look at the time course in the different types of secondary brain injury that happens after ICH. You can see here that the timeline goes to several days to almost like a week or so. And in the very hyperacute period and in the initial hours after ICH, we have to deal with the hematoma expansion and doing things that very urgently to try to prevent hematoma expansion. Over the next couple days, perihematoma edema becomes an issue and the mass effect related to that, in addition to the local tissue injury and ischemia that results from perihematoma edema. But we also know that after ICH, it's not just the blood and the bleeding that's the problem, but there's also ischemia that happens in the brain. And we know from recent studies that there is evidence of ischemic injury after ICH, even remote from the hematoma. As you can see here, this is an MRI image of a patient who had an ICH here on the left, and there's evidence in this DWI sequence of infarctions, even in contralateral to the hematoma. So essentially, all of this, the edema, the expansion of the hematoma leads to elevated ICP, impaired cerebral perfusion pressure, impaired oxygen delivery, and eventually even ischemia in the brain. And all of this contributes to poor outcomes. So I want to discuss a little bit of what we know about the different types of radiographic secondary brain injury after ICH. One is perihematoma edema, which is essentially fluid that extravasates probably due to disruption of the blood-brain barrier that we know occurs after ICH. Also related to the inflammatory response from the blood products in the brain parenchyma itself. And some preclinical studies also suggest that iron toxicity is related to the formation of perihematomal edema that you can see in these images. Interestingly, perihematomal edema has not been consistently shown to be an independent risk factor for poor outcomes, but it definitely doesn't help patients. And there is a very strong interest in trying to develop therapies to prevent perihematomal edema. Ischemia, however, after ICH is actually much more consistently associated with poor outcomes in independent models looking at this. And it's thought to be caused by hypoperfusion, which can happen if you have a very high ICP. The brain is often suboptimally perfused. We often decrease iatrogenically, like lower the patient's blood pressure in the setting of an acute ICH, and that can cause harm as well and contribute to ischemia. Patient also there are changes in there's impairment in oxygen delivery to the brain that can get affected. The mass effect of the hematoma can cause arterial compression and compromise the blood supply to the brain and lead to ischemia. And there's also inflammation triggered by the blood, and inflammation we know can lead to microthrombosis and may also be contributing to ischemia after ICH. And you can see some examples here of the remote ischemia that I mentioned, the lesions here remote from the hematoma, but you can also have infarction of brain tissue adjacent to the hematoma, and that's often due to the mass effect. Iron toxicity, I mentioned a little bit that how iron toxicity is an issue, and this is a specific issue in ICH as opposed to the other types of stroke, and it's because there's blood products in the parenchyma itself, and this has to be broken down. And the breakdown products of hemoglobin and heme is free iron, and free iron is very toxic to the brain. It leads to oxidative stress and cell death, including a type of cell death called ferroptosis. We unfortunately don't have a direct way to look at this in the brain. There's no radiographic marker of iron toxicity, but preclinical studies show that this is an important factor in brain injury after ICH. And in fact, there was a clinical trial that tried to decrease iron, essentially circulating iron in patients with ICH to see if that could help prevent secondary brain injury and improve outcomes. And they gave intravenous deferoxamine. This was the IDEF trial, an iron chelator to patients. But unfortunately, even though the preclinical studies were very promising, clinically it didn't really pan out, and the trial actually had to be stopped early for futility. I want to focus a bit on hematoma expansion and how important it is. Because, and this is kind of what we do in the urgent setting for ICH, right? Is try to prevent hematoma expansion. It occurs in the initial hours after ICH ictus, so it requires like acting fast, and it's known to be essentially the largest acute preventable driver of poor long-term outcomes. And people may debate on what is a definition of hematoma expansion and come up with different cutoffs. But this study here from 2011 showed that no matter what cutoff you use to define hematoma expansion, if it's 3 cc's increase hematoma or 33% increase hematoma, consistently any hematoma expansion associates significantly with poor outcomes with pretty high odds ratios, as you can see here. I have also done some work looking specifically at intraventricular hemorrhage expansion because that's sometimes people dismiss that a bit, but looking at data from the CLEAR 3 trial, which was a trial that looked at intraventricular fibrinolysis for intraventricular hemorrhage, we showed that we looked at that data set and separated patients who had any IVH expansion, even anything of 1 cc or more expansion, and those who did not have an expansion. And that factor, if you adjust for ICH severity and other confounders, is an independent risk factor for poor outcomes. So what do we do to prevent hematoma expansion? So blood pressure control is a big one, right? We focus very much on the blood pressure, and you might be wondering why we have the guidelines that we have. You may remember from dealing with ICH patients that we will often recommend lowering the blood pressure to a range of 130 to 150. But where does this data come from? It's not quite straightforward. The optimal blood pressure goal for patients is not something that we have a very defined clinical trial that showed us that. Essentially, we have two big trials, the Interact-2 trial and the ATAC-2 trial. Both of them looked at intense blood pressure lowering to less than 140 versus what was standard at the time, which was less than 180. They had a little bit different designs, but overall, they kind of compared these two ranges of blood pressure control. And the Interact-2 trial showed evidence that intense blood pressure control led to improved outcomes, but this was only one type of analysis with an ordinal shift in MRS analysis. So it was promising that intensive blood pressure control is good for patients, but the ATAC-2 trial did not reproduce that, and in fact, it showed that patients in the intensive blood pressure lowering group had higher rates of AKI. So there's a potential to cause harm by lowering the blood pressure too much. So subgroup analyses were done from these trials, and it was determined that lowering blood pressure to less than 130 can cause harm. In addition to renal injury, it can also cause cerebral hypoperfusion, and then that could be detrimental. So to balance that and still have an impact on hematoma expansion, the goals that seem to be the optimal for all comers is lowering the blood pressure to a range of 130 to 150. So that's where that comes from. So I'm going to talk also now about other ways to address hemostasis and prevent secondary brain injury, specifically hematoma expansion after ICH. And this is what the body normally does essentially when there is bleeding, vascular injury and bleeding, which is what happens in ICH. There's initially the platelet plug formation, then the coagulation cascade gets activated, and a fibrin clot is formed. And that fibrin clot sometimes is not so stable and can be lysed through fibrinolysis. So a number of studies have pretty much targeted different points in this pathway here to try to improve outcomes for patients with ICH. So the first trial that I'm going to talk about is the PATCH trial, which addressed what happens here and at the level of the platelet plug. And it wasn't standard of care. Before this trial, it was standard of care for any patients who were on an antiplatelet medication to receive a platelet transfusion. So the thought was that giving them normal platelets would allow them to form this clot in a better way and achieve hemostasis and presumably improve outcomes. But it turned out that when this was tested in a clinical trial, patients on antiplatelets were randomized to receive a platelet transfusion or not, or to just receive standard of care. It turned out that giving a platelet transfusion actually caused harm, and patients had a worse mortality if they got a platelet transfusion and worse MRS scores long term. So that changed the practice remarkably, and essentially we stopped giving platelet transfusions for patients with ICH who had been on previously been using antiplatelet therapy. Interestingly, this trial excluded surgical patients, so this does not necessarily apply for patients who get surgery, including an external ventricular drain or hemicraniectomy for ICH. And also, this trial was not quite powered to look at patients on dual antiplatelets. So there might be still a role for platelet transfusions in that specific population. Another interesting trial in looking at achieving hemostasis faster for ICH patients was the FAST trial. The FAST trial was for all comers with ICH, not only those on an antithrombotic or anticoagulant. And this was looking at giving activated factor VII to patients with ICH in an attempt to try to promote coagulation and clot formation to see if that would improve outcomes. And that was the window to give that medication was 4 hours in this trial. And they did either, like, they tried two different doses of the activated factor 7 as well as placebo. And it turned out that there was no difference in outcomes. As you can see here, no difference in survival, no difference in long-term MRS scores. But there was also no differences in adverse events. Giving the activated factor 7 did not lead to worse thromboembolic events, worse rates of thromboembolic events. So this story might still, this might not be the end of this possibility that this medication could help patients with ICH. And in fact, there's a ongoing trial that's following up the FAST trial, which is called the fastest trial. And this aims at giving this medication, the recombinant factor 7 factor, within 2 hours of ICH ictus. So if you guys have a patient with an ICH, you're responding to an RRT, for example, and the patient is less than well, is within the last 2 hours, please call us. You can call me so we can potentially get the patient enrolled in this trial. Another important trial for ICH was the INCH trial that identified the best way to reverse vitamin K antagonists, so warfarin, and compared FFP to PCC, and found that patients who got PCC had less hematoma expansion. There was also a trend towards better survival in the PCC group, although it wasn't significant. Definitely, PCC is much better in reducing the INR quickly. This was significant over here. And there were no differences in adverse events. So this changed practice, and we now use PCC to reverse vitamin K antagonists and not FFP. This is a more controversial trial that was published recently, and this was an ANEXA-1, and this tested what's the best way to reverse factor 10A inhibitors, so apixaban, rivaroxaban, etc. And this was sponsored by a pharmaceutical company that makes, makes andexanet alpha, which is the specific antagonist to factor 10A inhibitors, and compare this to what they call usual care, which in most cases was Kcentra or PCC. And their primary endpoint was a composite score of hemostatic efficacy that included hematoma expansion and neurological deterioration. And they actually did achieve their primary endpoint. So it seemed like andexanet was more effective in preventing hematoma expansion. However, they did not show that it led to better outcomes. And the most troublesome part of this trial is when you look at the adverse events, specifically the thrombotic events, because andexanet, the patients who got andexanet alpha had much higher rates of thrombotic events, and that was significant. And specifically, they even had more arterial thrombotic events, and ischemic stroke was one where there was like a big difference. Patients who got andexanet alpha had a 5 times higher likelihood of having ischemic stroke after their ICH compared to usual care, which was mostly PCC. So this, even though this trial did achieve their primary endpoint, many neurointensivists have not adopted andexanet alpha for reversal of factor 10A inhibitors because of this concern for stroke, especially since there's no differences in long-term outcomes. So currently, we don't do that at Sinai. Actually, andexanet is not available at Sinai, so our practice is still to use a PCC to reverse factor 10A inhibitors. And then at the end here of this pathway, the fibrinolysis phase, which is important process for clot stability. It has been attempted, like an antifibrinolytic has been attempted in ICH, and this was the TISH-2 trial that looked for in all comers with ICH. Patients received TXA within the first 8 hours of less known well, to see if that could potentially stabilize the clot and allow them to achieve hemostasis and improve outcomes. It turns out that it didn't really show a benefit. There was no difference between groups in terms of long-term outcomes for MRS. But this might also not be the end of the story here. I think there's potentially room to look into the benefits of TXA a little bit more. If you look at their subgroup analysis for patients with hematoma volumes of 30 to 60 cc's, there was a benefit of TXA. And importantly, there were no difference in adverse events or including like thrombotic events. So a follow-up study for this would perhaps make sense. So the current guidelines for reversal of antithrombotics are here. As I mentioned, the vitamin for vitamin K, what we do now is PCC, not FFP, in addition to vitamin K for vitamin K inhibitors here. For the DOACs, the bigger trend has its own reversal agent, which is Prexbind, which is available at China. So that should be used in cases of the bigger trend, which is not very common for us to see. But the more common that we see DOACs that we see people on are factor 10A inhibitors. And here, the guidelines, which were published in 2022, before the next one trial was published, still includes andesonate alpha as acceptable, just as for factor PCC, depending on what's available at the institution. But I really wonder if these guidelines are going to change in the next reiteration of it after the next one trial was published. So we'll see. And then for heparins, there hasn't been any specific ICH trials on heparin reversible. So what we do is what's standard of care for any other bleeding related to heparin. So we give patients protamine. And I want to make a couple comments here. One is that platelet transfusion is not recommended, as I mentioned, based on the patch trial for reversal of antiplatelets, and specifically for non-surgical cases, although it's recommended for patients with thrombocytopenia. And you might be wondering why I didn't mention the DAVP at all. And that is because there is actually no phase 3 clinical trial on the DAVP. There's a lot of retrospective data showing that the DAVP can be beneficial in reversing antiplatelet effect in ICH. So we do give it, and it's recommended. However, we don't have yet phase 3 clinical trial data to support that practice. So this is a summary of blood product transfusion practices in ICH, which is something that I'm very interested in from a research perspective. And I just want to summarize the different types of blood products out there and like what we do in the setting of ICH. So FFP, I mentioned, no longer recommended for reversal of warfarin. So we do use PCC instead. However, there's still a big question of whether we should use FFP or PCC in patients who have a coagulopathy related to liver disease, for example. There is no good trials for that. There's only retrospective studies. And I don't think we have a good answer for what blood products to use, if it's FFP or if we should actually give Kcentra. For platelets, I did mention that it's not standard anymore to give platelet transfusions for patients on antiplatelets. However, if there's thrombocytopenia, the general practice in the field is to transfuse for a goal platelet count of greater than 100,000. No trials have ever been done to really show that that's the right target for patients with ICH, but it's general practice and it continues to be what the guideline says. So that's the indication for platelet transfusion if the patient actually has thrombocytopenia. Cryoprecipitate, the current guidelines don't mention cryo at all as having a role in ICH and reversal of coagulopathy. They also don't mention checking fibrinogen at all. I have a little bit of an interest in this. I think we could be missing some occult coagulopathy by not checking fibrinogen, and perhaps some patients could benefit from cryo. And then red blood cell transfusions. Obviously, we're not going to use red blood cell transfusions to achieve hemostasis, but perhaps there's a role in using red blood cell transfusions to improve oxygen delivery to the brain. And I'm going to talk a little bit about some data on that. But currently, the guidelines, because there hasn't been any ICH specific trials on red blood on hemoglobin thresholds, the current guidelines are to target a hemoglobin greater than 7, and it's based on the TRIC trial, which kind of applies for all critically ill patients, including patients without brain injury. The next slides are a lot focused on my research and some of my specific interests. So I would say that I have like two main research interests in this field. One is whether we can improve transfusion practices in ICH to prevent secondary brain injury. And another one is, what is the impact of systemic inflammation in ICH and how can it be mitigated? So I'll start by talking about transfusion practices. So we talked about the patch trial. Looks like transfusing some platelets for these patients can worsen mortality, so people kind of stay away from it. But I have some data that suggests that um, perhaps we can improve our practices and the quality of the platelets that we give to patients. Currently, it's not standard for platelet units to be matched for ABO compatibility, and in ABO incompatible platelets are often given to patients. We found I did some work in doing fellowship and found that in a cohort of patients who received a single platelet transfusion in the initial 24 hours after ICH. We looked at those that received an incompatible ABO incompatible platelet unit and those who received the ABO compatible platelet unit. And if you adjust for medical disease severity, ICH severity, etc., what we find is that patients who received an incompatible unit actually had a higher mortality, hospital mortality specifically, and also had a worse platelet bump. Essentially, their platelet recovery was not as optimal as patients who received ABO compatible units. So there might be some room to improve platelet transfusion practices, and it could still have a role in management of ICH patients. Um, Another interest of mine is occult coagulopathy. So we know that about 20% of patients with ICH, they come in with a known coagulopathy. Either they have a lab abnormality that we can see, prolonged PTT or INR, or low platelets or low fibrinogen, or they come in with a history of taking an antiplatelet or an anticoagulant. Um, 80% of patients have no evident coagulopathy. However, 20% of these patients go on to develop hematoma expansion. So the question is, are we missing an occult coagulopathy? So one way that perhaps we can measure coagulopathy a little bit better may be using viscoelastic hemostatic assays, which include ROTEM and TAG. I'm going to make a case for that just by saying that the lab values that we get, the PT and PTT assays, are essentially done without cells. So blood gets spun down, the erythrocytes are completely removed, and these assays are done just with the plasma. However, the fibrin clot contains cells. You can see all the red blood cells that are in the clot. So it's a more dynamic process than what it's measured in the lab. And the ROTEM and TAG essentially uses whole blood and is able to calculate specific features of the clot that are more than just clotting time. So it's time to clot formation, but also it measures the clot strength and the rate of fibrinolysis. And this is data that can be useful when we're trying to prevent hematoma expansion in ICH. And this is an example of a patient with ICH who had hematoma expansion, and turns out that their labs were completely normal. They had normal coags, normal platelets, everything. But when you did a ROTEM, you can see that they had occult coagulopathy. Their clotting time was prolonged, and they also had a weak clot formation. And I wanted to share with you guys here also a little bit of our experience in the Mount Sinai West near ICU with ROTEM. In the past last year, we were able to run some ROTEMs by borrowing the machine from OB anesthesia, and we did it not just for ICH patients, but for patients with other intracranial hemorrhage or even non-intracranial hemorrhage, like a head and neck patient. And I would say, and this is a kind of a summary of what we found, and I would say that overall it was very useful. 3 out of 10 in 3 out of 10 cases, we actually gave blood products based on the ROTEM. In another 3 cases, the ROTEM provided us with some reassurance for emergent surgery in a patient where we didn't know their complete past medical history or their list of home medications. In 4 cases, we didn't identify any coagulopathy and sometimes a little bit of hypercoagulability, which made us
Why
take a
don't you
step
let
back,
Andy
made,
go?
made us take a step back and before giving additional blood products. And in many cases, we found that Rotem identified a coagulopathy that wasn't really evident in the routine labs. And you can see a couple examples here of a patient where there was some evidence of hypercoagulability with a little bit of hyperfibrinolysis, but we decided to not like give give as aggressive with blood products because we were concerned that we could cause thrombotic events. So I think this was helpful for this patient. And this is another example where the patient did not have abnormal labs, but we found prolonged clotting time and actually gave FFP to this patient before going to surgery. I think that there are clinical tools that may improve our acute management of ICH. One is potentially the Rotem, and I hope that we can in the future obtain a machine for the ICU, especially at MSW where we see a lot of ICHs. And also, I'm looking to checking fibrinogen for all the patients that come in with ICH. It's not standard practice, but our group of neurointensivists have agreed that this makes sense to do, and maybe I can come up with some data to show that this may be a quality improvement for us. Now want to switch gears, but kind of still on the topic of transfusion, perhaps, but talking a little bit about anemia in ICH. So anemia has been very consistently linked to ICH outcomes, and this is usually anemia that patients come in on admission with. So these patients who have lower hemoglobin, if you adjust for other confounders, ICH severity, etc., across the board in many different studies, this has been shown to be associated with poor outcomes. We also know that in addition to come in with anemia, patients also develop further anemia while they're in the hospital. And this is very similar to critically ill patients in general. They drop their hemoglobin. It's very common. We see this all the time in the ICU, and this has been demonstrated in ICH patients. This is an example from a study by Kevin Cheth showing patients who get transfused and who don't, and both of them have this drop in hemoglobin, and the nadir seems to be around day 2 or 3 after ICH. If we look at data from other types of brain injury, where sometimes patients get invasive monitors like a bolt where you can measure, in addition to ICP, intraparenchymal oxygenation in the brain, so like a PbTO2 measurement. There's data from patients with subarachnoid hemorrhage and TBI who get monitors like this, that higher hemoglobin levels leads to better oxygenation in the brain. And we have seen in ICH, this is an example of a patient. This patient with ICH didn't have an invasive monitor for oxygenation, but had NIRS, which is a non-invasive, indirect way of measuring a proxy of oxygenation in the brain. And we saw here in this patient that if you track the NIRS numbers over time, after they get a red blood cell transfusion, there's a bump in their oxygenation in the brain. So perhaps increasing the oxygen delivery capacity can improve oxygenation in the brain. So in the subarachnoid hemorrhage field and in the TBI field, they have already done clinical trials to look at this question specifically, and these trials actually published last year. And these are the results. Essentially, the first one, the Sahara trial, looked at a liberal hemoglobin target of greater than 10 versus a restrictive one of greater than 8, and looked at long-term outcomes, etc. And what they found is that they didn't really achieve their primary endpoint of improved outcomes, but there was a clear signal towards benefit. And most importantly, the liberal hemoglobin goal, the liberal transfusion strategy patients did not have any increased rates of complications in the hospital. So that was somewhat reassuring. And overall, I think people in that field thinks that there should be additional trials done to look at this in subarachnoid hemorrhage specifically. In TBI, the trial that tested this was called HEMOTION. It was published last year as well, looking at target hemoglobin of greater than 10 versus greater than 7. And here, they also didn't reach their primary outcome. There was no difference in long-term outcomes. And it seemed like the liberal strategy was associated with the higher index of like pulmonary issues, specifically ARDS. So here, it actually seems like maybe it caused harm. But remember that the TBI population may be very different from stroke populations, right? ARDS is a lot more common in TBI and like in even like pulmonary edema is a real thing in TBI, more so than other types of brain injury. So I think this specific population may be a little bit different. But my point is that this has been tested specifically in subarachnoid hemorrhage and in TBI, but there are no trials yet to test this in ICH specifically. Um, there are retrospective studies looking at this in ICH, and one study, this is published in 2011 by Kevin Sheth, actually showed that if you adjust for medical disease severity and other confounders, patients with ICH who got a red blood cell transfusion, there was an association with lower risk of mortality. So this was reassuring that maybe there is potentially a benefit, but this hasn't been consistently reproduced. I actually looked at this question using the National Inpatient Sample an administrative data set to see if we could see this link between red blood cell transfusion and outcomes, specifically mortality, hospital mortality, after adjusting for disease severity based on the Charleston Comorbidity Index. And we couldn't quite reproduce like a benefit of transfusions, but definitely saw that if when we did the adjustments, like there was not like a less of a link between red blood cell transfusion and mortality. So this is more work that needs to be done. I have also looked into complications related to red blood cell transfusions in ICH specifically, and this is work that I did during fellowship. In our cohort, we looked at hospital complications that happen in ICH patients after a transfusion and comparing to the rates of complications that happens in patients who didn't get a transfusion. And the hospital complications that we were interested in included thromboembolic events and infections, and we found that getting a transfusion does not increase the risk of having these types of hospital complications. So it seems fairly safe to give red blood cell transfusions for patients with ICH. And then this takes me to the more recent study that was actually positive for for liberal red blood cell transfusion strategies in brain injury patients. So this is not a trial of a specific type of disease. So it looked at brain injury in general. So and it included patients with TBI, subarachnoid hemorrhage, and ICH. ICH was the minority here group with was less than 20% of patients had ICH. There were more patients with TBI and maybe about a little over 20% of patients with subarachnoid hemorrhage. So all these patients were kind of pulled together, and the arms were either a liberal strategy for transfusions targeting a hemoglobin greater than 9 versus a restrictive strategy targeting a hemoglobin greater than 7. And this trial actually was positive. It showed that a liberal transfusion strategy was associated with a lower risk of unfavorable neurological outcomes. And this was the first trial that for the first trial for liberal red blood cell transfusion that actually included patients with ICH. So this is quite promising. I think the next step is really to do a trial for ICH patients specifically. In this question of hemoglobin and outcomes, etc., I have also done some work to try to understand the mechanism by which different hemoglobin levels can cause poor outcomes. And one hypothesis is that it causes impairs oxygen delivery to the brain and causes maybe ischemia. So we looked at the associations between this was for admission hemoglobin and both ischemic lesions in the brain and outcomes. And here we found that there is a complex relationship, and it also depends on whether the bleed is deep or lobar, but the relationship seems to almost have like a U-shaped curve where a very high hemoglobin is detrimental, but a very low hemoglobin is detrimental as well. But remember that we're only looking at admission hemoglobin and not necessarily at the changes in hemoglobin that happens over time while patients are in the ICU. So I followed up on this work, actually looking at the trends in hemoglobin over time in ICH patients. And this is something that got published recently this year and included a cohort from my fellowship at Columbia and also a cohort from Sinai, specifically a cohort of patients who underwent minimally invasive hematoma evacuation. And we showed that decrements in hemoglobin happen across the board, essentially, and patients who have ischemic lesions in the brain have more of a drop in hemoglobin. Patients who have poor outcomes also have more of a drop in hemoglobin. And when we do multivariable logistic regression analysis, adjusting for many things like ICH score, medical disease severity like Apache 2 score, in time to MRI, etc., we found that across the board, there is a very clear association with a greater hemoglobin decrements being associated with higher odds of developing ischemic lesions on MRI. So this could be a mechanism by which, higher hemoglobin target could help patients, could prevent secondary brain injury. Now I'm going to talk a little bit about my interest in systemic inflammation in ICH. To start with, I'm going to say that the inflammation after ICH definitely happens, but it's not really limited to the brain, right? It's seen in systemic markers as well. And this is very well described in markers of systemic inflammation, such as neutrophil to lymphocyte ratio, and things like systemic inflammatory response syndrome scores, SIRS scores, independently predict ICH outcomes. So that's been very well reproduced. I have also found that these markers of inflammation, like SIRS, for example, on admission, and I specifically was looking here for patients who had minimally invasive hematoma evacuation, that also predicts ischemic lesions in the brain. So it may be that inflammation is an important factor in leading to secondary brain injury after ICH as well, and specifically inflammation that we can measure systemically in circulating blood. This is some data that I haven't published yet, but I've collected from patients who underwent minimally invasive hematoma evacuation and comparing those patients with a matched cohort of patients that have had very similar demographics and ICH severity, as you can see here. So you may be aware that we at China do a lot of minimally invasive hematoma evacuation. And this is an illustration of the procedure here. The idea is that removing the blood from the brain parenchyma can improve the secondary brain injury that happens because of the blood. And my hypothesis is that removing the blood can decrease the inflammatory trigger that causes a lot of the problems that we see downstream. So I looked into measuring the neutrophil to lymphocyte ratio of patients who got SCUBA, minimally invasive hematoma evacuation, and match cohort over time, and to see how they compare. And you can see here that the change in neutrophil to lymphocyte ratio is quite different. They have a quite different trajectory if you compare the SCUBA patients to the match cohort, with the match cohort having a lot more inflammation. So this is a hypothesis. This is hypothesis generating, and the idea is that perhaps minimally invasive hematoma evacuation may work and improve outcomes by reducing systemic inflammation. I have also shown that the anemia that patients develop after ICH also seems to be a response to inflammation. It seems to be an anemia of inflammation. And this was shown based on data from the high-def trial. There was one of the trials that used the iron chelator to try to treat for ICH patients to see if it improved outcomes. That trial had measurements of iron transferrin saturation and ferritin for patients at different time points. So we were able to look at that and demonstrate that the anemia that ICH patients develop is consistent with an anemia of inflammation. And in a separate cohort, we saw that SIRS scores associate with the hemoglobin decrement as well. Going back to transfusion practices and ABO incompatible platelet transfusions, I have some data showing that ABO incompatible platelet transfusions in ICH, in addition to being associated with higher mortality and worse platelet recovery, also seems to be associated with ischemic lesions in the brain. And this is a paper that's currently under review. And the mechanism of that we propose, and the additional studies would have to show this, but it's known that ABO incompatible platelet transfusions leads to circulating immune complex formation, and that can be inflammatory. And again, it's linking this idea of systemic inflammation in secondary brain injury and poor outcomes after ICH. Um, one other one other finding in ICH that may perhaps link anemia with inflammation and be an important factor here, and perhaps a therapeutic target for ICH, is hepcidin. I'm not sure if you're familiar with what hepcidin is. It's a hormone that's produced and secreted by the liver in response to inflammation, and it's known to be the mediator of anemia of inflammation because it prevents iron reabsorption from the gut. So there's less iron available for erythropoiesis, and patients who have a high hepcidin end up developing anemia. And it's triggered via the IL-6 pathway. And there's data in ICH in both patients and in preclinical mouse model studies. So in patients, it's known that serum hepcidin goes up after ICH about 3 days after ictus, as you can see here, which correlates very well with the anemia of inflammation that we see. Iron levels go down just as hepcidin levels go up. And you can see that there's a correlation between hepcidin levels and iron levels in ICH patients. And this study also looked at long-term outcomes and showed that higher hepcidin was associated with worse outcomes. And actually, low circulating iron was also associated with poor outcomes. So there could be a link there to explain why patients after ICH develop anemia, and why, and maybe this is related to why they develop poor outcomes as well. This group also looked at this in a mouse model, and they were able to actually access the brain in the mouse model and look to see what happened to hepcidin in the brain. And hepcidin was also increased in the brain, just as it was increased in the serum in the mouse models of ICH. And it turns out that hepcidin was linked to more brain injury and iron toxicity in the brain because it prevented iron from being from kind of leaving the brain, and iron gets trapped in the brain because of the way hepcidin regulates the only iron exporter that exists, which is ferroportin. So this is something that I have looked into the literature quite carefully in terms of what papers are out there and studies that have been done on hepcidin as it may be related to ICH. And I wrote a review on this, and it's currently being peer reviewed. But this is my hypothesis that ICH induces inflammation. The IL-6 pathway has been consistently shown to be upregulated in ICH, and this is known to upregulate hepcidin, which we know inhibits ferroportin, which is the iron exporter. So there's less iron available for erythropoiesis, and it also may have a function in the brain where the brain cannot basically secrete iron out into the circulation, and it gets trapped in the brain and causes more toxicity and neuronal injury. So this is something that needs like additional work to be explored. And this brings me to my future project, and it's what I plan to do in the future to further explore this topic. If I can get funding to support this, I hope to conduct a prospective study to investigate inflammation and iron metabolism in ICH. There are three things that I'm interested in. One is to compare and define what's the relative contribution of the brain versus systemic inflammation in ICH. And to do that, we would be looking at analyzing samples that are collected from the hematoma evacuation from the brain itself and blood from the circulation and inflammatory biomarkers there. I'm also interested in investigating how SCUBA, or minimally invasive hematoma evacuation, can impact outcomes, perhaps by attenuating systemic inflammation. So again, looking at these biomarkers over time in patients with ICH. And I also want to examine the relationship between hepcidin, iron, hemoglobin, and also MRI markers of ischemia and outcomes to see if this hypothesis that I have that hepcidin may be important for outcomes, pans out. So in conclusion, I hope I have convinced you that hematoma expansion is a very important and probably definitely the primary modifiable predictor of poor outcomes of ICH. And want to emphasize how important it is to focus on blood pressure control and coagulopathy reversal when you're managing patients with ICH. I also hope I have shown that secondary ischemia after ICH is an important determinant of outcomes, and perhaps there is room there for developing therapies to target that mechanism, understanding the mechanisms of secondary ischemia and targeting that to improve outcomes. And also that there may be a lot of room to improve transfusion practices in ICH, and I think more studies are needed there. And I also think that further research is needed on the systemic inflammation after ICH and also and how it relates to iron metabolism. So I would like to also acknowledge and say thanks to some of my mentors who have helped me with this work and all my collaborators as well, which includes people at Sinai, people in other departments as well, and actually in other institutions as well. Any questions?
Thanks for that really comprehensive overview, Fernanda, and really some interesting points on where ICH research is going. Any questions from the group? All right, I guess we'll wrap up. Thanks, Fernanda.
No problem.
Yeah, so I have a couple of questions. One is, when the intracranial hemorrhage occurs, is it a global blood-brain barrier defect or local, or does it make a difference? The other is the timing of transfusion. Is that a factor in outcome?
I think Fernanda already left the lecture. I'm sorry, Norma.
Yeah, I know. I had a hard time just unmuting myself. I don't know why.
Okay. Next time, Norma, if you need her email, let me know and I can provide it.
No,
Otherwise,
send me the email because I'll ask her.
otherwise, thank you, everyone.
Thank you. It was a great talk.